I'm Dr. Matthew Herring, an orthopedic traumatologist currently working in Redding, California at Epic Orthopedics. This video is for the placement of an anterolateral distal tibia plate. The plate is applied through a typical anterolateral approach to the distal tibia. I create an incision in line with the fourth ray centered over the tibiotalar joint. C-arm fluoroscopy may also be used to confirm incision placement. We will first cut skin. During this approach, the first structure at risk is the passing superficial perineal nerve. This should be identified and protected. Here's the crossing superficial perineal nerve. Again, this will be identified and protected through this dissection. In this particular case, I'm going to retract it and protect it medially. Next, we incise through the fascia. As well as the retinaculum of the tendons. The tendons of the anterior compartment are mobilized and then retracted medially to expose the underlying distal tibia and tibiotalar joint capsule. Retractors may be placed to facilitate exposure. We have the capsule identified and will incise through the capsule to gain access to the joint. Care should be taken to limit the amount of dissection of the capsule off the distal tibia in an effort to preserve blood flow to the fracture segments. Now we're in the tibiotalar joint. This completes the exposure of the anterolateral distal tibia. At this juncture, the surgeon would proceed with mobilization of the fracture fragments, reduction and temporary fixation using surgeon preference on technique. We will at this point in time proceed with placement of the anterolateral distal tibia plate. Inside the set, you'll have options of 7-hole, 9-hole, and 11-hole available to you. Additionally, 13-hole and 16-hole lengths are available upon request. So now we will place the anterolateral plate. It is pre-contoured to fit the native anatomy of the distal tibia. The surgeon may temporarily position and K-wire the plate or use the provided olive wires. The plate is inspected to see that it is appropriately seated and positioned. Additionally, C-arm fluoroscopy may be used to confirm plate position. A unique design feature of the screw is their dual lead threads, allowing for quicker placement. During placement of the anterolateral plate, I typically start with placing 1 to 2 non-locking screws along the shaft of the plate to lag the plate down to bone and finalize its position. I then turn distally and apply my locking rafting screws. Another unique design feature of this plate is the locking holes, which feature a variable angle 60-degree cone. We will begin first with drilling the distal row. Again, these will engage the anterior lip and then measure with the provided depth gauge. And this measures a 50. And either locking or non-locking screws can be applied here depending on surgeon preference. For a rafting screw, I will apply a locking screw. This measures to 48. At this juncture, the olive wire may be removed. After finalization of the construct, the surgeon then proceeds with layered closure per surgeon preference.